Welcome to this CMB Bite Size briefing regarding the Meningitis B outbreak in the Kent and Canterbury cluster. If you are a primary care professional, community pharmacist or frontline clinician, this video is for you. Before we begin, please hit the like button and subscribe to the channel to help us reach all of our colleagues. You will find a direct download link to this full presentation, as well as the Primary Care Ready Reckoner document in the video description below. We must start with a mandatory clinical disclaimer: acceptance of liability and source verification. This presentation is provided as a summary for primary care professionals managing the Meningitis B outbreak. While every effort has been made to ensure the accuracy of the antibiotic dosages, prophylactic schedules, and clinical guidance contained within, no liability is accepted for any errors, omissions, or typographical mistakes. The current situation is changing rapidly, and therefore clinical guidelines and outbreak protocols are subject to rapid updates. Healthcare professionals must exercise their own independent clinical judgment and are strictly advised to check and verify all drug dosages, contraindications, and clinical pathways against the original, up-to-date source documents before initiating any patient treatment or prophylaxis. Let's look at the data as of the 18th of March 2026. We are tracking 27 total cases connected to this cluster, 15 are confirmed, 12 are probable, and 9 are confirmed specifically as the MenB strain. Tragically, there have been 2 fatalities. The epidemiological focus is strictly concentrated on students at the University of Kent campus, local sixth form pupils, and anyone who attended Club Chemistry in Canterbury between the 5th and 15th March. Although now there are reports that cases are now being reported in other areas and countries. When identifying cases, clinical diagnosis of meningitis or septicemia, combined with onset since the 1st of March and a link to Canterbury, makes a probable case. Please remember that all suspected cases are statutorily notifiable. You must notify your local health protection team immediately upon suspicion. Do not wait for microbiological confirmation. There are a number of things to consider regarding the MenB vaccine. 2 doses of the MenB vaccine helps protect individuals against meningococcal B disease. It is important to know that the MenB vaccine does not protect against all strains of meningococcal disease, nor against all infections that can cause meningitis. It also does not prevent the bacteria from being carried and spread in the community. For example, where 4C MenB, Bexsero, is recommended in a cluster/outbreak situation, the 2 doses should be offered with a 4-week interval for those aged 1 year and older because of the need for early protection, which, in these circumstances, would outweigh the need for longer-term protection. It is important to emphasise to vaccinees or parents of vaccinees that the vaccine will only start protecting around 2 weeks after the 2nd dose, and therefore they should remain vigilant for symptoms and signs of meningococcal disease. Additionally, if 4C MenB, Bexsero, is administered without confirmation of potential strain coverage by the vaccine, vaccinees/parents of vaccinees should be made aware that the vaccine may not protect against the circulating strain even after 2 doses. It is therefore still hugely important that people are aware of the signs and symptoms of invasive meningococcal disease, and that they seek immediate medical attention if they or anyone they know develops these signs and symptoms. Why is this spreading in this specific demographic? The vulnerability lies in the 2015 immunity gap. The MenACWY vaccine, given routinely in schools, does not protect against MenB. The dedicated MenB vaccine was only added to the infant schedule in 2015. Therefore, the current cohort of university students and young adults are immunologically naive to this strain and lack baseline protection. To manage the public health shield, we must understand transmission. This bacteria is not airborne like COVID-19. It requires close, prolonged contact with respiratory secretions, such as living in the same confined university halls or intimate kissing. The risk to the wider public outside of these vectors remains low. Make no mistake, speed is the defining factor here. Meningococcal disease is bacterial, carrying a 5 to 10% fatality rate. A patient can deteriorate from mild, flu-like symptoms to a fulminant, life-threatening condition within hours. Minutes matter. There are two phases to this infection. Meningitis, which is the inflammation of the brain and spinal cord lining, and septicemia, which is blood poisoning. Crucially, do not wait for a rash. You can develop fatal meningitis without septicemia, meaning a rash may never appear. You must be on high alert for the classic triad: sudden high fever, severe crushing headache, and extreme neck stiffness. Other diagnostic red flags include photophobia, confusion, and unusually cold hands and feet, even in the presence of a fever. If a rash does appear, use the glass test. Press the side of a clear glass firmly across the rash. A standard rash will fade under pressure. If the rash does not fade, meaning it retains its red or purple colour, blood is actively leaking into the tissue. This is a medical emergency. Your immediate next steps depend on the patient's path. If they have symptoms, call 999 or transfer to A&E immediately. If they are an asymptomatic, eligible close contact who has returned home, prescribe prophylactic ciprofloxacin immediately. Do not refer them back to the university clinics. Furthermore, ensure you follow up-to-date NHS England and UK HSA guidance for further actions, so these patients are appropriately safety netted once they leave your care. For prophylaxis, the first-line choice is a single stat dose of oral ciprofloxacin. Adults and children 12 and over receive 500 mg. Infants under 1 year receive 30 mg per kilogram up to a maximum of 125 mg. Do not delay treatment if liquid suspension is unavailable. Crushed tablets mixed with food are a clinically suitable alternative. If you suspect the disease and hospital transfer is inevitably delayed, administer pre-hospital IV or IM antibiotics immediately, provided you carry them. We recognise that many community pharmacists and primary care clinicians will not have access to IV or IM antibiotics. Therefore, prioritise the 999 emergency transfer and do not delay. If you do have access and are competent and able to do so, the preferred first line is ceftriaxone. Administer 2 grams stat to adults and children weighing 50 kilograms or over, or aged 9 years and above. Do not administer if there is a severe penicillin or cephalosporin allergy. If ceftriaxone is unavailable, your alternative is benzyl penicillin. Administer an immediate single dose of 1.2 grams stat for adults and children aged 10 years and over. Ensure paediatric patients under 10 are dosed strictly by age guidelines. To synthesize your checklist: suspect the disease based on triad symptoms, transfer as an emergency, and actively protect the public by referring to the appropriate antibiotic clinics. Ciprofloxacin can be prescribed to asymptomatic exposed contacts. For infection prevention and control, apply standard respiratory hygiene and contact precautions. Utilize Level 2 PPE specifically for airway management or when dealing directly with respiratory secretions. That concludes our summary for this outbreak. If you found this breakdown helpful, please give the video a thumbs up, subscribe for more clinical updates, and share this with your colleagues. Don't forget, you can download this complete slide deck via the link in the description. As a final reminder, we must repeat our disclaimer. Acceptance of liability and source verification. This presentation is provided as a summary for primary care professionals managing the Meningitis B outbreak. While every effort has been made to ensure the accuracy of the antibiotic dosages, prophylactic schedules, and guidance contained within, no liability is accepted for any errors, omissions, or typographical mistakes. This situation is evolving rapidly, therefore clinical guidelines and outbreak protocols are subject to rapid updates. Healthcare professionals must exercise their own independent clinical judgment and are strictly advised to check and verify all drug dosages, contraindications, and clinical pathways against the original, up-to-date source documents before initiating any patient treatment or prophylaxis. Thank you for watching.
Like and subscribe.